Hi everybody. There's a topic that keeps going around in circles and circles and seems to hit brick walls and dead ends, and it relates to the bringing together of ideas of ear, nose and throat when it comes to airway and breathing problems, and dentistry when it comes to how the jaws and teeth may develop. So what was interesting in this conversation was a publication that came out in the middle of this year in the most prestigious journal for pediatric ENT in the world. It's called the International Journal of Pediatric Otorhinolaryngology. And it was an article that came from Finland where they brought together a range of specialties and went through the literature to try and clarify whether ear, nose and throat and dentistry and orthodontics need to be interacting more. So this involved the Department of ENT at the university that conducted the study, the Department of Oral and Maxillofacial Surgery, the Department of Dentistry, and the Department of Social Sciences. And they all came together to look at the literature and see what was going on. Now, one of the problems that they encountered was the quality of that literature. And I think partly this is because we don't have much in the way of ear, nose and throat and dentistry interactions going on. So we have dentists trying to be ENTs and ENTs trying to be dentists, and it doesn't work very well. But they did the best they could, and what they found in the research that they published was that there were definitely some changes noted in terms of how the jaw and teeth were growing in children that had airway obstruction, in terms of the trajectory those children continued on if they did not have their airway obstruction relieved by surgery, versus the children in terms of the trajectory they then followed where they did have surgery. And the surgery was to help the children breathe better. The dental changes were considered an incidental curiosity, but it was a curiosity that they pursued to try and clarify if there might be some advantageous outcomes from ENT surgery. And if there is, then whilst this may not be a reason to do the surgery, if a child is having jaw and orthodontic problems and there are favourable changes from said surgery, then it would seem reasonable and logical to make sure that any child with airway obstruction and orthodontic problems gets the airway sorted first, so that whatever jaw and dental changes that are favourable of an improvement can take place. But also it would make sense then that any orthodontics that needs to follow could in theory be quite easier to follow through with, because you have some changes that are happening without you needing to do anything in the first place. So if it's wanting to go in a different direction to what it was doing, once the child can breathe better, and that direction is the direction that a dentist or an orthodontist would want the teeth and jaws to be going into, and would be instituting treatments to make that happen, well, there's a little bit of a kickstart to progress. And where the conversation, I think, gets lost is people want to make this a black and white absolute scenario. There is no absolute black and white scenario in medicine. It's relatively straightforward. We, for reasons that we don't fully understand, notice that children turning up to ENT clinics have a much higher rate of jaw and orthodontic problems than children who have normal breathing. We also notice that children turning up to orthodontic clinics, usually motivated by the parents because the teeth and jaws are crooked, who are then assessed from an airway point of view, have an airway problem that is far higher than the general population. Now, that's not to say that one's causing the other and vice versa. What it is saying is that there's a huge number of children turning up with two problems. And the concerning thing for me is that dentists and orthodontists that want to cast aspersions to this conversation will say that, except maybe in very severe obstruction, that there's no reason that getting the obstruction fixed for jaw and teeth problems is warranted. The point being is that if they've got an airway problem, it warrants treatment. I don't know why they keep going on about the fact that it does or doesn't make a difference to the jaw. That doesn't matter. Likewise, we don't want to be in a situation where people that focus on airway problems from a dental point of view think that all they need to do is the dental things, and that will sort out the breathing problem, because that's not the case either. So much as I've done since probably around about 2009, when I was approached by one and then more and then more and more and more dentists who had concerns about children they were seeing and were noticing airway problems, I've worked very hard to have a collaborative approach. And through that collaborative approach and that somewhat unique experience, delving into the ENT literature, delving into the dental literature, delving into the orthodontic literature, and at times not understanding what I'm reading about dentistry and orthodontics because that's my background, but at least absorbing the information as best I can, and then synthesizing that with the clinical experience, which now is well over 10 years worth of interacting and learning from dentists, turning up to dental courses, orthodontic courses as an ENT, to learn about these things, to get a better understanding about these things, so that I have a better understanding of what I'm seeing and what people believe may be the cause of those problems, and then seeing how that may possibly then relate into the sort of treatments that I do, and then getting the feedback again and again on a very consistent basis now from the dentists that say, wow, this child is so different. And they're just talking about the child in a general sense. The child is able to sit in the chair and breathe. They're not choking and gagging and struggling in the dental chair like they used to. I have dentists that feed back to me that say that they can see jaw and teeth changes starting to happen in front of them since the surgery or what other treatment was appropriate has been done. And I have some people that have been doing orthodontics longer than I have been doing ENT, who have done the orthodontics just like they would do, and as every other sort of orthodontic aligned practitioner would do, but then noticed some airway problems, started sending them to me, and then started to feedback that their orthodontic treatments were proceeding so much easier, so much better, so more stable. Now, of course, these are all anecdotes. I'm happy for people to shoot me down. I'll get in first. Yes, they're anecdotes. But we're talking about well over 10 years now of helping children breathe better. If their jaw and teeth development is also improved because of that, hey, look, I'm happy that's a nice little bonus. But we need to really put an absolute end to the argument, end to the discussion about whether breathing causes orthodontic problems, because it doesn't matter. It doesn't matter, because we have a child who does not have enough oxygen going to their brain. We have a child that is getting high blood pressure because their sympathetic nervous system is overactive. We have a child that has metabolic derangements that affects their blood sugar and their cholesterol, for example, because of low oxygen levels. Whether we want to waste our time arguing about crooked teeth and jaws whilst this child continues to not be able to breathe properly, it's a bit like turning up at a traffic accident, and you can see that the person has got a broken leg, and you're arguing about how they got the broken leg, and meanwhile the person's also got a punctured lung and they're not breathing and they're about to die. The reason that we approach trauma, we do ABC, it's airway first, breathing, and then circulation. The fractured leg doesn't matter, just like the crooked teeth and jaws don't matter, because airway is well above the list, and the consequences of airway, such as brain and cardiovascular issues, are way above the list. So what I would like to finalise and just conclude, just to give you some numbers, It's estimated, depending on which papers you read, that 40 to 60% of children turning up to an ENT clinic with some form of breathing obstruction also have an orthodontic problem that needs management. Spinning it the other way, a child that is presenting to an orthodontic clinic just purely because of crooked teeth, 40 to 80% of those children have a breathing problem. We're not arguing about cause and effect. We have to identify coexistence of disease. And when we have two problems, we need two solutions. We need the airway sorted and we need the orthodontic sorted. And I would kindly suggest that before any sort of breathing retraining or jaw aligners or expanders or braces or any other orthodontic treatment that's out there, myofunctional therapy too, before any of that started, if there is any suggestion of a breathing problem, that could be as simple as just mouth breathing. ENT first, airway first. Thanks.